To me, consent means being explicitly asked if I'm comfortable with something happening to my own body.
Hello and welcome to another episode of the HSE Talking Health and Wellbeing podcast. My name is Fergal Fox and today we're talking with our colleagues in the HSE National Office for Human Rights and Equality Policy about consent in the context of health and social care services. So this is a fundamental thing in relation to how we deliver and receive health and social care services. So it's going to make for a very interesting chat. To all our listeners, thank you again for your continued support of the podcast. Please share this episode with anyone you think it's relevant to. And if you'd like more information about HSE Health and Wellbeing, follow us on Twitter or X, take a look at our HSE Health and Wellbeing YouTube channel, or register for our e-zine by emailing healthandwellbeing.communications@hse.ie. So, my guest today is Elaine McCaughley, who's the Programme Lead in the HSE National Office for Human Rights and Equality Policy. Hi Elaine, you're very welcome to the podcast.
Hi Fergal.
So we're talking about the HSE National Consent Policy. I know you've been doing a range of things trying to get the word out across the HSE to health and social care staff about this policy and about the priority messages in it. By way of introduction, what do you tell people that you're working on for the HSE?
Yeah, we're all familiar with the various consent campaigns going on at the moment for the general public, and we're doing something similarly targeted messages for staff in relation to consent in health and social care. And that's about involving the person in any decision making, putting them at the centre of any decision making when it comes to providing a health or social care service. So really any care or treatment or intervention needs to start with consent from the person.
So this is going to be familiar with people. I think everybody that's got a health or social care service. When I was talking to you a few days back about this, it was reminding me of the way the doctors talk to us, and I expect them to talk to me. And nurses, I'm doing this, I think this, so is it okay? Asking things like that. That's just an everyday health checkup that you're in there and they're talking to you before they do anything, basically.
And that's exactly what the HSE National Consent Policy expects us to be doing as healthcare workers. That we're not doing anything to someone or on someone without a valid consent. And that applies to all interventions carried out by or on behalf of the HSE. So it's about explaining what you're proposing to do, what the reason for it is, any risks or benefits associated with it, what would happen if you didn't do it, any alternatives, and providing that information to the person themselves in a way that they can understand so they can make their own decision. Yeah.
It sounds such a simple concept, doesn't it? At one level.
Yeah.
Because you think, well, this is fundamental.
Yes, I suppose it's a very human rights-based approach to delivering services. But unfortunately, historically, it's not the way it has always been delivered. I know Bernard Gloucester, when he spoke to you on another episode of your podcast, he spoke about the historical power imbalances and paternalistic approach that people would have experienced when they accessed services in the past. So the National Consent Policy really brings to life this human rights-based approach where the person themselves makes the decision. And I suppose the areas where that's most radical is for people who have historically been denied those rights and have not been asked for their consent or for their permission, and who have had decisions made on their behalf, possibly on a doctor knows best kind of approach, or possibly by other people, by family members. So really this is putting the person and their rights front and centre.
I think many of our listeners may have experiencing both types of interaction with health services. That conversation where the health provider is talking to you, as you said there, trying to get consent, drip feeding you the information at every step. It's not just like saying something at the end. And then the other type where they're just telling you, this is the story, you'll have to do this.
Yeah, I think a good consent process is really well married in with the values of the HSE. Trust and compassion, and that relationship between a person using a service and the healthcare worker is massively enhanced, and the outcomes are massively enhanced by a good consent process where the person feels they are being kept up to date, they can trust their healthcare worker, and they're part of the decision making.
Yeah, as I said a few minutes ago, this is part of a campaign you have going across the health service, trying to get the word out to all staff working in the health and social care arena. And you have some lovely clips of service users themselves talking about, what consent means to them. Let's play one of those clips now, because I think it's really powerful when it's put in the patient or service user voice.
To me, consent means being explicitly asked if I'm comfortable with something happening to my own body.
Consent, for me, is about me being part of the decision. It's about my life.
Consent is the express authorization or approval of a person to allow somebody else to do something on their behalf or to represent themselves in a situation. Basically is interpreted as my free will to represent myself and my own needs.
So you can really hear the impact that a consent process has on people using services. When it's done well, it hugely enhances their experience. And when it is not done or when it's done poorly, it can have a really damaging and lasting effect on their interaction with the service, on their outcomes and of their general perception.
I know we're maybe overusing the word fundamental here, but maybe we're not, because your interaction has to be health enhancing. Mm-hmm. Whatever ailment or sickness you have, the last thing you want is to have your self-esteem or anything taken, or what you said, there's a power imbalance potentially, unless we address it by having this consent policy, isn't there?
Absolutely, yeah. And it really is. It's all healthcare workers. It's every intervention. It's an ongoing process of communication with the person while they're receiving a service.
You mentioned there that it's an ongoing piece. So let's think of that dream scenario intervention. You know, you're bringing your child into a healthcare professional and you're sitting there and the doctor or nurse or whatever. What's the kind of things that you want to hear them say when they know the policy and they're taking this kind of consistent approach in relation to talking to the patient? And what would that sound like?
So that's a really interesting example, because I suppose in that situation where you have a parent or guardian bringing a child to a service, it is the parent or guardian who will give the consent, but the child has a right to be involved in the decision making. So that healthcare worker should also, as well as bringing the parent or guardian up to speed on what they're proposing and listening to their questions and concerns, should equally be trying to explain it to the child in a way that they can understand, and listening to any concerns that the child might have or any other supports the child might have in order to be able to assent to the process.
I'll give you another harder example. Let's say I'm going to visit my father and he's got dementia, he's in a home, and I want to make a decision about his care with the staff in the centre where he's staying. Like, if that's done really well, what does that sound like to you?
When that's done really well, the family member, yourself in this example, your views as to your father's preferences are given a huge amount of weight and respect, because you obviously know him very well, you care for him, and you're a really good advocate for what he would want. And when that's being done really well, your role there as his supporter and supporting his views, his will, expressing his will and preference, if he's maybe not able to do that, that's made very clear to you that that's what's happening here. You're not making, and you shouldn't be being asked to make a decision on his behalf, but you can communicate what your father would want, or you can support your father to communicate what he would want in this situation. And that's a real key shift, I think. Culturally, historically, there has been a perception, a false perception, maybe, that family members can make decisions on behalf of another adult. That's not the case. That has never been the case, unless you have a particular legal authority, such as you have been legally appointed as a designated healthcare representative. So in normal situations, most situations, families are hugely valuable in representing the views of that person who may not be able to represent their views about a treatment decision at that time. But it's very important that the healthcare workers are clear that they're not asking you as the son to make that decision. You can't consent on behalf of your dad unless you have that specific legal authority.
Okay, that's interesting. But as you said, you're adding weight to the consultation with the family.
Family, or whatever person knows this individual the best, you know. In so many different scenarios, it might be the next door neighbour, it might be a close friend, it might be somebody that the person has named themselves as X is the person who helps me make certain decisions. And really, that kind of individualised approach to support, who can support this person, who does this person want to support them, to get their voice in the centre and their wishes and preferences central to the decision making.
So when you consider consent, like, it's a really, really powerful part of healthcare.
Mm-hmm.
You broke it into 3 different pieces that have to be there. Can you bring us through those 3? Because I think, they really kind of flesh it out.
Sure. So for a consent to be valid, and no intervention should proceed without a valid consent, the first thing you need to be certain of as a healthcare worker is that this is a voluntary consent, that the person is making this choice of their free will. They're not under any pressure or any duress to consent to the intervention, and that they know that they have the option of refusing, and they also have the option of changing their mind later on. So that's really, really important. And again, coming back to that power imbalance, it's really important to be aware of that when you're thinking about, is this person making a voluntary choice, and have all the other options being explained to them. The other piece, I suppose, then I've referred to already, is the information piece. That the person has been given sufficient information in a way that they can understand, and they've had a chance to go away and think about it.
From a communication point of view, it can be challenging then, can't it? Like even the scenarios that we just mentioned there with the father with dementia, or the son or the child, in healthcare with the mother, and the health professional has to talk to mommy,
mm-hmm.
talk to daddy, and has to talk to the child,
mm-hmm.
and make that a kind of consistent effort to do that. The communication skills here and the levels that, the words that you're using, like it's all really live stuff.
It really is. And I suppose with that example we discussed with the father with dementia, a message I really need to emphasize is that every adult is presumed to have capacity to make this decision for themselves. So the fact that a person has dementia, or is in a nursing home, or is in a disability service, or any other diagnosis or age or feature, does not
take that off them.
Okay. Again, the example of the son visiting the nursing home. We're presuming that dad has capacity to make his own decision. The son being able to flesh his wishes out, or support his communication, or give examples of decisions dad made in the past that might be relevant to this. This is all trying to support dad's position as a decision maker.
Okay, but the second piece, anyway, in terms of valid consent, is the person has been given the information in a way they can understand.
Yeah.
So that takes a bit of reach, and it may take effort depending on what the issue is, what's presenting. That's the responsibility of the healthcare professional.
Yes. So some people will require more support to understand that information, and they may need it in different formats, whether that's a diagram drawn with them as the consultation is taking place, or a link to a YouTube video, or really breaking down information and chunking it into very simple pieces, and maybe having a number of consultations to make sure the person understands what's involved. And I suppose that comes back to that idea of support. What are the best supports for this person to enhance their ability to exercise their right to consent on their own behalf?
And the next piece then is the capacity. The valid consent means the person has the capacity to decide about the intervention. Where do we start there?
Well, we start with the presumption that every adult has the capacity to decide about an intervention. And there's an obligation for healthcare workers to start from that presumption and to support that person as far as they reasonably can to make that decision for themselves. After that, if a person's capacity to decide about an intervention is in question, or if they clearly lack capacity to make this decision, the updated version of the National Consent Policy, which was updated in January of this year, provides a lot of guidance in Section 5 and 6 on how to proceed in that situation. So you might be aware that last year in April, the Assisted Decision-Making Capacity Act was finally commenced. So we're coming up to the year anniversary of the commencement of that act. So it's really getting bedded down in implementation now. And the general principles of that Assisted Decision-Making Act should be applied in that situation. So there are a lot of provisions to that act, and we probably don't have a lot of time to get into it.
So when that capacity issue is a challenge, we've developed a specific policy called Assisted Decision-Making to help us through the various issues that might occur there.
There's a law called the Assisted Decision-Making Act that covers all sorts of decisions, not just healthcare decisions, but that has been embedded. The principles of that legislation are embedded in the National Consent Policy. So they come into force, and that's around the obligation to provide the support to the person to make the decision for themselves, and also the importance of the person's will and preference. So the updated consent policy will step you through if this person lacks capacity to decide about this intervention, but it seems consistent with their will and preference. It's the kind of thing they would want, they would have agreed to. And the intervention is clearly for their benefit. And the people who must be consulted, so that would be any decision supporters they've appointed, the person, family member or friend that is closest to them as a supporter. If they all agree that yes, the person would have wanted this, then the policy does provide guidance on how to proceed and provide that intervention in that case.
So there's a lot to engage with here. One bite isn't going to get you to consume it all. So can you just give me a flashback around our own HSE consent policy?
Yeah.
It started in
2013 was the first HSE consent policy. And then this was revised and issued in 2022. And that was very much anticipating the Assisted Decision Making Act.
That's a big thing that's in since last year, that's been updated in this year's policy.
Yeah.
As you say there, that takes us through some of the more challenging parts of this, really. Is that fair?
Yeah, it really gives us, the Act gave us reforming legislation around this human rights piece.
Right.
Your listeners will remember the ward of court system, where decision-making powers were entirely taken from an individual and made by the court or by their committee. So the Assisted Decision Making Act replaces that wardship system and very much establishes various supports to keep that person and their will and preference central in decision making. So that is throughout the HSE National Consent Policy. We issued the revised policy in 2022 because it was taking a very long time for the Act to be commenced.
Okay.
It had been signed into law in 2015, but it hadn't actually commenced. So we launched as much of the policy as we could in 2022. And we're very happy, January of this year, to be able to capture all the other legal provisions that are now in force.
So in terms of some of the challenging areas that you'll have to bring this out to and air it out and get loads of examples to kind of work it through with staff, that's what you're doing at the moment through your series of webinars that you've planned, isn't it?
That's right. So we have an event for considerations in mental health services. So looking at how the National Consent Policy operates in mental health services. And the way we run our webinars is we ask staff to submit their real life scenarios, their real life questions that are arising in their services. Anyone can sit down and read the policy or look at our resources and do our e-learning program. And we really recommend that they do the e-learning program.
They're on HSE land, I presume.
It's on HSE land, yeah. But staff really seem to appreciate the opportunity to pose the real life, tricky, messy scenarios that they're facing in their practice and actually have that talk through in relation to the consent policy. How is this supposed to operate?
That's definitely really needed. Like, it is messy sometimes, you know, and the real world experience. And I would have thought in mental health is going to be one of the sensitive areas for this. That, like, sometimes people think, you know, going back to the scenarios, like if I think somebody in my family needs to be in a mental health service and they don't think they need to be in a mental health service. And traditionally, was that without the consent policy being there, was it always fair what was going on? We didn't have that human rights approach in the past.
Yeah, now there is another piece of legislation, the Mental Health Act, which applies in that situation as well. And I suppose that's where this can get a little bit tricky.
Okay.
What is the overlap? How does the Mental Health Act sit with the National Consent Policy and sit with the Assisted Decision Making Act? And that's why this webinar will be really helpful, I think, to staff in just mapping that out, because they don't contradict each other. They can be operated very well together.
Yeah, it all comes back to the power, though, doesn't it? And the way that you're having your conversation or even approaching the conversation with the patient or the service user, bringing them along the journey of your thinking nearly.
Yes, and respecting them as a rights holder to make their decision, even if they may really struggle to make this decision for themselves. So lacking capacity to make a particular decision should not be used as a barrier to, you know, participating in what's happening in your own life. Yeah,
one of the things that I think that we'll have to do as healthcare staff is give that time. I know we spoke about the communication challenge there sometimes, but the time to work through. And I'm very bad at this now. If I'm in with a healthcare professional and they're talking to me, it's sometimes I'm on instant forget mode. Like, you know, what they said isn't going in.
Yeah.
I have challenged retaining that. Like, I'm only getting 10 minutes of their time and they're telling me something. I'm just picking it up in spots.
Yeah.
And I'm guessing I'm not the only one. If they're offering me choice? Am I going to get a chance to ruminate or discuss? And then that's a time challenge for the health professional, I guess. You know what I mean?
It can be a time challenge and also a timing challenge, because as you say, people want to ruminate or realize what it was, the piece of information that they forgot. What is the piece that they don't understand? Time is very precious, and healthcare workers are under huge time pressures. Services can prepare themselves a little bit for doing a good consent process. For example, looking at common procedures that they carry out and maybe producing a very simple patient information leaflet that would capture the main information about that. Now, that's not to say that just handing in a leaflet to a person is the same as giving them information in a way that they can understand, but it's a really good starting point. If a healthcare worker would sit down with you, Fergal, with that leaflet, talk you through it, and you could bring it home, then...
Yeah, there's much more chance that's going to stick.
Yeah.
Or I have a prop to ruminate with, or if I need to consult with somebody to say, look, if I'm going in for this care now, I need to do this, or if I'm not doing it, I need to do that.
Yeah.
That's very important as well. That challenge needs to be named, I think, for the health professional. You know, that time challenge, that explainer challenge, that capacity challenge. I can see very strongly the huge value in this, but it's a time and it's a cost in terms of the thinking things through from healthcare professionals as well.
Absolutely. But I think that comes back to that power imbalance piece.
Yeah, okay.
So doing consent well may put more obligations on the healthcare worker, but doing the cost of not doing consent, or the cost of doing consent poorly, not informing a person, not allowing them to make their own decision.
When this isn't done well, if it's not health enhancing, if it's not empowering, it's doing the opposite. It can be damaging. I'm sure you're aware of a lot of examples of that.
Yeah, and the profound impact it can have on a person, on their health outcomes, but also on their perception of the service, trust in the service and the healthcare worker, and their own well-being when they feel that their rights or their choices were overridden, or they weren't involved in making decisions about what was happening to their own body.
So we're going to listen to another clip from one of your resources here, which has a patient or service user talking about how they felt when they weren't treated with that empowering approach. And just have a listen to this and see what you think.
The experience was that I was having a really lovely, empathetic relationship with the midwife, and I felt very part of every decision that she was making. And then the consultant came in. Because she was just doing her job and she had a job to do, I almost fell out of the equation. I was just, part of her job. She just didn't involve me in any way. Her conversation was over my body. I was just left there on the table until the conversation was done. So it just left me feeling really like a piece of meat, to be honest. You don't feel human. You just feel like a cog in their job. So it's just remembering that it is a human, and although it's something you probably do every day, working on these bodies and doing X, Y, and Z, but it's just taking a second to breathe and go, okay, this is a new person. How do I treat this person in the way that I would like to be treated if I was sitting in that chair and I was scared and worried and all of those things?
So that voice of the person is so powerful, and that idea of being a cog in someone else's job, I think that really illustrates that whole idea of the machine that is a health service, and the huge power imbalance for the person in the centre of that, and how this ongoing process of communication that the consent policy requires really helps to even out that power imbalance, helps to balance it out and make the person feel that they're involved, they are valued, they are respected, and they have not handed away all of their rights.
I mentioned when I was talking to Bernard Gloucester as well about the storytelling that our patients do.
Oh, yeah.
Like I was thinking about my parents, storytelling to all their kids and all their in-laws and friends in the community about their healthcare interactions. Those people, and I think particular people in their 60s, 70s and 80s, every conversation is like, how are you? Well, such and such, I'm getting this ailment, or I'm going here for that, or I'm going there for that. So those health conversations and their stories about interactions with the health services are going into all their phone calls and all their doorstep meetings and their outside the church meetings or wherever they're meeting people around town. So it has this multiplying factor. Absolutely.
And that could be someone who had a really good health outcome, but didn't feel that they were listened to, or felt that, as that lady said, didn't feel human, felt like a piece of meat. That's the story that will be told. That's the impression that is left on that individual. So they might have had very successful surgery or whatever the intervention was, but what lasts and what will be talked about is how they were made feel.
Yeah. No, I was just a bit taken a bit, like the most recent story, fortunately from my parents, has been very positive. But they literally recounted the whole conversation with the health professional.
Yeah.
You know, and I thought, well, if this level of detail has been shared, then woe betide us if we're not fixing our conversations with the people out there, because they're just getting multiplied and duplicated.
Yeah.
So we can create our own positive wave of engagement, or we can negate it by, you know, polluting the pool, I guess.
Yeah, that's it. It does come down to trust. The person wants to trust their healthcare worker. And if you're open with them, giving them all the information, being available to answer questions, respecting their right to withdraw their consent, and being happy to explore the reasons for that with them. I mean, that is a very supportive, trusting interaction. We do have an example of an older lady with dementia talking about her challenges around consent, and maybe listening to her voice, I think, would be far more powerful than my own.
It isn't consensual for people with dementia in many cases. This is what we think. And you're vulnerable. And you're going to go away and think, well, this is what I have to do. This is what I have to take. So it can have a devastating effect.
So it really goes to show that some people do need that extra bit of time, that extra support, and really to be empowered to make the decision for themselves rather than feeling they need to bow to other people's opinions.
Yeah. That probably caps it off there, Elaine. Is there any last call out? I want you to signpost to your website there, and just, you know, there's a lot more meat on the bone here for the different areas that you're trying to support. Like you mentioned mental health there in the upcoming webinar, but I'm sure you'll be doing an ongoing series of them.
Yeah, we have our website is hse.ie/nationalconsentpolicy. So you'll find everything there, the policy itself, an easy read document of the policy.
I saw that. Yeah, well done on that. Yeah.
Yeah. There's information on all our webinars, and all of those are recorded, so you can look back, isolate particular scenarios that might be of interest to you, and any of our upcoming events. There is an event with dentists in intellectual disability services on the 6th of June. And we have a mailing list as well that we send a quarterly newsletter out to, as well as the e-learning program on hse.ie. So anyone who'd like to join our mailing list could email national.consentpolicy@hse.ie.
Okay, thanks very much, Elaine. I really want to thank you for your participation today and joining us to talk about, like, this is very important. Like, we keep using that word fundamental, and it is that. So thanks for coming onto the podcast and sharing your insights.
Thanks so much, Fergal.
And to all our listeners, thanks for joining us again. And this has been another HSE Talking Health and Wellbeing podcast.